Well, again, thank you for joining North Kansas City Hospital's event. Tonight, we are talking about post-stroke rehabilitation, and we have the amazing Stephanie Ramirez here with us, who is just going to tell you everything you possibly need to know. So, Stephanie, I'll hand it over to you.
All right, thank you. And thank you everyone who is tuning in live and maybe those who are tuning in later from the recording. This is a great topic. I feel like a lot of people have been personally affected by stroke, or someone in their family has had it. So just understanding kind of the process and what could be going on is really great, and having that knowledge ahead of time. So I am also, just to let you know, a speech language pathologist. I work primarily in the outpatient setting at North Kansas City Hospital, and I've been a speech pathologist for 11 years now. So I have had extensive experience working with patients who have undergone treatment for stroke. So I thought we would start today talking about what is a stroke. I think understanding how the stroke affects the brain can really give you some great insight on how we decide on our rehabilitation plan. And we're going to talk about stroke recovery, and then really dive into what you can expect when you are in a rehab program. And then I will definitely try to leave some time at the end for question and answer. So just a big broad overview, a stroke occurs when the blood supply to part of your brain is interrupted or reduced, which prevents the brain tissue from getting oxygen and nutrients. You might also hear a stroke called a CVA, or a cerebrovascular accident. And there's actually over 200,000 cases of stroke in the United States per year. There are three types of strokes. Ischemic stroke, the first one, is the most common, and it's when the brain's blood vessels become narrowed or blocked. So you can see the blockage in the picture there, the graphic. It's not allowing the blood to flow through. So that is what we would consider an ischemic stroke. A hemorrhagic stroke is where a blood vessel in your brain ruptures or leaks. And although the brain is full of veins and blood vessels, blood is actually very toxic to brain tissue itself. So when that blood is kind of free flowing in the brain, that can lead to some extensive damage. The third type of stroke is a transient ischemic attack, or what some people call a TIA, or you might have also heard it called a mini stroke. And that's where there is a temporary period of symptoms similar to those who, when you have had a stroke. It's really not possible to tell if you're having a full stroke or if you're just having one of these TIAs based solely on symptoms. So it's really important to go to the hospital and get checked out. If you've had a TIA, most likely it means that you have a partially blocked or narrowed artery leading to the brain. And of course, having a TIA definitely increases your risk of having a full-blown stroke later on. So you definitely want to take those seriously, even though the effects might be temporary. So something that I like to share with all of my patients, and I think this is important for everyone to know, is the B FAST acronym for spotting the signs of a stroke early. Many of you probably know that time is of the essence. So B for balance. If you're having difficulty maintaining balance. E, you might notice eye changes or vision changes. F, facial drooping. A, arm weakness. S, speech difficulty. And then T stands for time to act. Don't ignore those or see if they go away. It's time to call 911 or get to a hospital. I also wanted to highlight some additional signs of a stroke for women, because women actually may experience a stroke differently than men. So women might have cognitive changes. They might have some hallucination, confusion, seizures, loss of consciousness. Hiccups actually are sometimes a sign of a stroke in women. Difficulty breathing and nausea or vomiting can also be signs. Now, obviously, these are can be signs of other things as well. So I would say definitely taking into consideration if you have an abrupt onset of these symptoms, and especially if they are in conjunction to one another. But just some ideas for women specifically to keep in mind. And now there are risk factors that increase someone's risk for having a stroke. So I just wanted to highlight those so we can also keep those in mind when we're thinking about prevention. So the first risk factor is lifestyle. So being overweight, being inactive physically, drinking, smoking, drug use, those are all potential risk factors for stroke. There are medical risk factors, so things like high blood pressure, high cholesterol, diabetes, sleep apnea, heart disease, if you have a personal or family history of stroke. And we have learned that COVID-19 infection also can lead to strokes, even in very young individuals. Some other risk factors are things like age. So people age 55 and older are at increased risk. Race, African Americans have the highest risk factor for stroke, and gender. So men have a higher risk than women. Women are usually older when they have strokes, and they're more likely to die of strokes than men. Also, when we think about men versus women, some use of birth control pills or hormone therapies that include estrogen can increase someone's risk of stroke. So again, probably one of these things is not going to make your risk factor sky high or, basically say that you're going to have a stroke. But I think if you have a multitude of factors, then you definitely want to be on the lookout and try to do your best to alleviate some of those factors. So if someone comes into the hospital for an acute stroke, they've started to notice these symptoms, they've been taken to the ER, what do we do? So typically with an ischemic stroke, if it's within 3 to 4.5 hours of those symptoms onset, you'll get emergency IV medication that can help break up the clot or the blockage in your brain. So obviously, the quicker these drugs are given, the better. And it not only improves your chances of survival, but it also reduces complications. And again, time is of the essence. So if you're outside of that 3 to 4.5 hour window, a lot of times the IV medication won't be effective and they won't administer it. There's also some emergency procedures that they can do. So they can deliver medication directly to your brain, where they insert a very long, thin catheter through an artery in your groin and actually goes all the way up to your brain to deliver medicine to exactly where that stroke is happening. They can also try to remove the clot. And after those procedures, or when someone's in the recovery phase, oftentimes they will also do procedures to help open up the artery that's been blocked by plaque. So you might have a stent placed or an angioplasty, again, where they thread that catheter through the artery in your groin and then inflate a balloon to help expand that artery back up to help prevent that from getting blocked again. Now, when there is a hemorrhagic stroke and you have that brain bleeding, there's some different procedures that happen. So typically the main goal is to help control the bleeding and reduce pressure in the brain. So they will administer in the ER emergency medications to help bring the pressure down. They might administer medications to counteract if someone's taking blood thinners so that they don't bleed as much. They also may do surgery, so clipping the blood vessels to help prevent more blood from getting out. There's also procedures called coiling and surgical AVM removal. So there's multiple procedures that they can do to help in the event of a stroke. But those are kind of the main ones that happen. And so just to kind of highlight our hospital, so North Kansas City Hospital is a Joint Commission certified primary stroke center. So that is in conjunction with the American Heart Association and the American Stroke Association. And it just reflects that North Kansas City Hospital has had long-term success in improving outcomes for stroke patients. And so as a stroke certified center, we do have telestroke specialists that are available 24/7. So in the event that someone comes into the ER at 3 o'clock in the morning, they will still be seen immediately by a specialist, evaluated, and get that treatment happening very quickly. So after that emergency treatment that we just talked about, you're definitely going to be monitored very closely for at least a day. After that, the stroke care really focuses on helping you recover as much function as possible and returning to independent living. So the impact of the stroke really depends on the areas of the brain that were involved and the amount of tissue that was damaged. So we're going to talk a little bit about how the body responds to a stroke. So for this graphic, it shows that if the stroke is in the right hemisphere, you're going to see changes on the left side of the body. If the stroke is on the left hemisphere, you're going to see changes on the right side of the body. So it crisscrosses there. And typically, again, we'll highlight what those changes are, but it's going to be on the opposite side of the body where the stroke occurred. Physical changes such as weakness and paralysis and so forth. Now, this graphic talks about kind of the brain function. So the right side hemisphere, again, the left side of the body would be affected, but you might notice changes in attention span, difficulty with impulse control, difficulty with drawing or visual tasks, difficulty recognizing faces, difficulty with managing and regulating emotions and having that really good depth perception. If the stroke happens on the left side, again, the right side of the body will be affected, but you also will have those changes primarily with speech and language. Again, emotion control can be difficult. Math concepts and writing can become difficult. Reading numbers, letters, recognizing objects, and memory can also be affected. Now, that's not to say that if you have a left-sided stroke that you won't have difficulty with some of those things on the right, but it's just what typically we see in those patients. Now, some other changes that you might experience after a stroke are severe fatigue. You might experience paralysis, weakness, or problems with controlling your motor movements. People sometimes experience incontinence, sensory disturbances, including pain. So that nerve pain, you might be feeling that. Some people experience visual impairments. So they have difficulty they might have some tunnel vision, they might have neglect on the side of the body where the stroke was. And in fact, about 2/3 of people will notice changes in their vision after a stroke. Emotional changes. So actually, if we go back one slide, you'll see that emotions are, emotional control can be affected regardless of the side that the stroke is on. And what we sometimes see is what's called the pseudobulbar effect, or PBA. And up to 50% of people that have had a stroke report experiencing that. And PBA basically is just uncontrollable bursts of emotion. So you might have hysterical laughter in 1 minute and then tears in the next. And this can be really concerning to family because they might notice emotions or personality changes that they had not noticed in the individual before. But it is very common, and typically it does improve or resolve over time as the brain heals. There is medication available for PBA if it is severe enough to inhibit their progress. But again, that emotion regulation can be very challenging following a stroke. Many people with stroke will also have seizures and epilepsy. Actually, 5% of people will have a seizure in the weeks following a stroke. And of those, some people do develop chronic seizures. And so again, they will have to be closely monitored. And then spasticity, that refers to painful or uncontrolled muscle movement or spasms that result from the stroke. So that is also something that we see kind of in that acute phase. So as we notice these changes in the hospital, people are going through those acute treatments, who is going to be involved in the care? So treatment team includes the doctor, of course, the nurse, dietitian, a physical therapist, occupational therapist, sometimes a recreational therapist, a speech pathologist, social worker, and a psychologist or psychiatrist as well. So a large team to manage many of those changes and get people kind of moving in the right direction following that acute stroke. And where does that treatment happen? So there are different options. So there is acute rehab, which happens inside the hospital on a separate unit, typically. There is also skilled nursing, which is, again, its own entity where someone can go and have 24-hour care while they are receiving their therapy. There is outpatient rehab, which someone would come into the office from home a couple times a week for therapy. And there's home health therapy, which can be offered if someone is homebound and they cannot get out to do their rehab. So rehab starts as early as 24 hours after the stroke. And really, as soon as the condition is stabilized, you'll start to do some exercises and work to sit up in bed, walk to the bathroom. Typically, as a speech pathologist, we'll be called in to check to make sure you're eating and swallowing safely. And, really that's because the process is different with everyone. And the stroke can affect so many different parts of the brain. We really need to get in there and figure out what's been affected and what abilities may have changed. And the key to improvement is really simple, and I'll emphasize this as we go, but it's going to be to keep practicing, keep going, and keep trying. So for someone who is kind of in the hospital in that acute phase, and they're trying to figure out what the next steps are, I've got some questions here that you may want to, take a picture with your phone if you want to keep these on hand. But questions that you might ask your insurance are things like, how much rehab is covered, what's the maximum that the person can receive, and what facilities or options are within your insurance network. Because obviously, the rehab process can sometimes take many weeks to months. And so you want to make sure that that is something that you are financially prepared for. And then when you're deciding on where to go for your therapy, first of all, it depends on your ability. So if the person is not able to come in physically to an outpatient clinic, then an assisted living or a skilled nursing facility or that acute rehab might be a better choice for them. So once you've kind of narrowed it down, you can ask the rehab director these questions. So you might ask them if they offer specialist stroke rehab, how they typically evaluate progress, what different treatments do they have available, where will it take place? Is it going to be in their room, or do they have a gym area? What kind of support do they offer for you, the family member or caregiver? Psychological support, is there support groups or somebody that comes around to talk to patients and kind of help them work through those feelings? How often will they see a doctor, and what will their schedule look like? Because when you're thinking about, and we'll kind of talk about this as well, I'm going to go back one page. When you're thinking about acute rehab, sometimes patients could be in therapy for 5 to 6 hours a day. And so it can be very vigorous. Inpatient rehab or skilled nursing, you might only be seen for 2 hours a day. outpatient rehab, you might only be seen for 1 to 2 hours a week. So just kind of keeping in mind how much therapy you think they'll need, how much your insurance will cover, and then how much that rehab company will provide. So just being very clear on kind of what the plan is and making sure that you're getting the care that you need. So as we move into kind of thinking about the stroke rehab, what I'm going to do is highlight each of the therapy team kind of goals that you might be working towards and kind of speak to those. So first of all, a patient will be seen by a physical therapist. So when we think about physical therapy, we're thinking about motor activities, walking, sitting, standing, laying down. You're going to be working on muscle strength and coordination. They're going to be working with you to see if you need any kind of assistive device like a cane or a walker. You might need a wheelchair or an ankle brace. So they're going to be evaluating to see what's going to help you the most. They also will probably work with you on range of motion. So easing that muscle tension, that spasticity that we talked about earlier, and helping you regain your range of motion. Now, sometimes following a stroke, physical therapy will also use things like electrical stimulation on the muscles to help them kind of get that, get woken up again. But they won't use that with everyone. So again, it's kind of nice to be able to talk to them and see what their plan would be and, you know, have some ideas in mind of what you might want to work on. Moving on to occupational therapy, this is more of those everyday activities where you're working on bathing, dressing, cooking, sometimes even reading and writing, using the toilet. So those fine motor tasks, those functional everyday activities that are going to help that person regain their independence. And again, they might be looking at things like splints or braces for the hand to help with some of that spasticity, as well as using that e-stim on the hand or arm to see if we can get some movement, some muscle tone back. Now, being a speech pathologist myself, of course, I can give you a lot of information about what speech therapy does for the patients. So our primary goal is to help everything from the neck up. So we're thinking about language and speaking, we're thinking about cognition, and we're thinking about safety with eating, drinking, and swallowing. So language and speaking skills. So again, typically we see this if the left side of the brain is affected where we have those language areas of the brain. But you might have several types of what we call aphasia. And aphasia is basically where you have a language disability. So expressive aphasia means that somebody is not able to express themselves. They might have what we call blocking, where they can't get any words out, or they might have just kind of jumbled up, kind of jargony speech that doesn't really make a lot of sense. Receptive aphasia means that they cannot understand the language that's coming in. So they might have trouble following directions or understanding when someone is talking to them. Global aphasia is when both of those things are impacted, both the expressive and the receptive language. And then when we think about cognitive deficits, we're going to talk a little bit here in a minute about vascular dementia, because that is something that sometimes happens after a stroke. But you might notice, shortened attention span, difficulty remembering things, difficulty making plans and problem solving and using good judgment, engaging in complex mental activities such as managing a checkbook or organizing medications. So those would definitely be things that we would make sure we worked on if somebody, was doing those things previously. And then as far as eating, drinking, and swallowing, that comes in when we're talking about the muscle movements and coordination. So after a stroke, the swallow is really a reflection of the rest of the muscles in the body. So if the muscles are weak, the swallow is going to be weak. If the muscles are discoordinated, the swallow is going to be discoordinated. And when that happens, you can have what's called aspiration, where food or liquid goes down into the lungs, and it can cause respiratory infections and all kinds of issues. So we really want to make sure that when people are eating and drinking, it's going down the right way. And if we need to, we can modify the consistency of the food to make it safer, and we can help provide exercises to build that strength and coordination of those swallow muscles. So diving in a little bit deeper into that cognitive component following a stroke, a lot of times those changes in thinking occur suddenly, but they can also be mild changes that gradually worsen as a result of multiple minor strokes or another condition that affects smaller blood vessels that lead to widespread damage. So you might hear the term vascular dementia. A lot of people now are also using the term vascular cognitive impairment. And typically these changes are also linked to another type of dementia. So they coexist with something like Alzheimer's dementia or Lewy body dementia. Typically, people do not have vascular dementia alone. Only about 5 to 10% of people are diagnosed with vascular dementia alone. And how are you diagnosed? So typically, you will have a neurocognitive test completed with several hours of written or computerized tests. Brain imaging is usually done, and that has to confirm a recent stroke or other vascular brain changes. So in vascular dementia here, you will see difficulty with making decisions, planning, reasoning. That should say difficulty following directions. Left a word off there. Slowed processing, difficulty with communication, and difficulty with reading and writing. So a lot of these are overlapping conditions with what we would consider Alzheimer's dementia, and that's much more widely diagnosed. But they will sometimes, if someone is known to have a history of stroke, they will also diagnose them with that vascular dementia as well. Now, there's no FDA approved drugs specifically to treat vascular dementia, but clinical trial evidence has shown that some of the drugs approved to treat the symptoms of Alzheimer's can also give some benefit to people with vascular dementia. And keeping in mind that these medications that are designed for the treatment of dementia, it really is primarily focused on preventing worsening of the symptoms. And, when we think about treating this as well, we're really focusing on treating the underlying disease. So, if someone is having recurrent strokes, they might need to be seen for better management of hypertension or diabetes, so that risk factor is addressed before the condition worsens. So when we think about outcomes following a stroke, again, stroke recovery varies very widely from person to person. And it's really hard to predict sometimes how many abilities a person is going to recover and how soon those abilities will recover. But in general, stroke recovery does depend on 4 factors. So we have physical factors. So how severe was the stroke in terms of the cognitive and physical effects? The emotional factors. So this has to do with the patient's motivation, mood, ability to stick with the rehabilitation activities outside of therapy. I often tell my patients, I only see you for 2 hours a week. So The rest of those hours outside of therapy is really where the magic happens. It's really where that recovery is going to take place. So you've got to be consistent with that home exercise. Social factors are things like family and friend support, being able to have somebody help at home with things or get you to therapy. And then those therapeutic factors. So getting an early start to that rehab and having a really good stroke rehabilitation team on your side that's going to help you. So the rate of recovery is typically greatest in the weeks and months after a stroke, but we are really learning more and more that that recovery can improve 12, 18, 24 months after a stroke, because the brain is always growing and developing new neural pathways around the damaged parts of the brain. So really that recovery plateau that they used to talk about, well, okay, after a year, that's it, or after 6 months, that's it, that's where you're going to be. That's really not the case. And I think that, if we cut patients off, we're really doing them a disservice. We need to keep going and, keep working to get them where they want to be, because change can happen. So from a therapist, some tips to get the most out of your therapy is, number one, really think about getting started quickly. So early intensive rehabilitation, again, improves the levels of recovery. So rehab should begin as soon as it's medically safe and feasible. Like we said, you will most likely be seen by PT, OT, and speech while you're even still in the hospital. So really getting that going. Again, don't buy into that recovery plateau, because that's not the case. It's known that continuing therapy can continue to yield functional improvements for many, many months and years after the stroke. So don't give up. Recruiting support from family and friends, doing the work at home, like I said, and addressing kind of those anxiety, depression feelings that you might be having that might limit your motivation to participate in therapy. I always tell my patients, I know that you're not working with me because you want to, because something good happened. I know it's something bad that, really changed your life. And so those big changes come with a lot of big feelings. And I think that addressing those feelings and acknowledging them and sharing them with a professional, or even getting medication if that's needed, can help you perform so much better in your other therapies, because you'll be in the right mindset to do that. And then finally, of course, we want to prevent another stroke from happening, because we don't want to start that whole process all over again and have it be worse the next time around. So very quickly, let's talk about some stroke prevention. So again, if you've had a stroke, you are at risk for a higher risk for another stroke. So 1 in 4 strokes are secondary, so they're recurrent. Somebody has already had a stroke. The chance of having a stroke within 90 days of a TIA, or one of those mini strokes we talked about earlier, might be as high as 17%, with the greatest risk factor during the first week. And all of that comes from the CDC. So it's very important to address those risk factors that we talked about earlier. So trying to get in there, control high blood pressure, hypertension. You should work with your doctor to help bring, that cholesterol level down to a normal range. You might need to change your diet. You might need to take medication to help lower your blood pressure. Of course, smoking greatly increases the risk of stroke and has been linked to the buildup of the fatty acid in the arteries that helps block the artery, or unfortunately makes the artery blocked in those ischemic strokes. It also raises blood pressure and makes blood thicker and more likely to clot. So really, taking some smoking cessation steps would be a great idea. Exercising, of course, maintaining a healthy weight, staying active. A body in motion stays in motion. And then we kind of talked about the heart and the cholesterol. And then diabetes also can cause destructive changes in the blood vessels throughout the body, and that includes the brain. So treating diabetes can delay the onset of complications that can later increase the risk factors for a stroke. So kind of to overview that stroke recovery. So in the first few weeks, our focus is intense daily exercise that's focused on those functional daily activities, bathing, dressing, walking, eating, talking, really thinking about getting in there, figuring out what has been affected and what we're going to need to work on, and developing that discharge plan as a team. What's going to be the safest place where you're going to get the most support. You might, notice again in those first few weeks that trouble with emotion regulation. You might find that somebody is really tired and sleeping all the time, or maybe they're having trouble sleeping. So basically kind of getting that person stabilized, working through those acute changes, and then figuring out what the next plan is. So I think it's important to remember, you don't have to be at 100% to return home after a stroke. If you can perform most of your daily activities, or you have family that's able to assist you with those, then you can go home. But if you can't, then it's going to be time to look at those other options like the post-acute rehab, skilled nursing, home health, and so forth. In the 1 to 3 months after a stroke, again, we're still focusing on rehab. We're really thinking about restoring that function as close as possible to pre-stroke levels, or if we can't fix it, then developing compensatory strategies together that is going to be a workaround for that impairment. So, learning to brush your teeth with your non-dominant hand if your dominant hand was affected. Learning to use an iPad or a picture communication system to help you fill in the gaps if you're having trouble thinking of the words that you want to say. So we really think about therapy as half restorative and half compensatory. So we try to get somebody back to where they were, utilizing both of those avenues. During this time, you might notice what we call spontaneous recovery. So during the first 3 months, especially, the patient might have a sudden, return of an ability that was lost. I think it's also important to really just anticipate that there will be setbacks in the months after a stroke. A second stroke, like we've already talked about, is sometimes likely to happen. You might have a heart attack. You might have pneumonia from aspiration, like we talked about earlier with the swallowing. So it's not that that's something that someone's doing wrong. It's just part of that recovery process. And sometimes that means therapy might have to be put on hold for a little while. But it's important to work with your care team, readjust those goals, and get yourself back on the right track. Now, when we think about 6 months plus post-stroke, we really focus on some of those chronic impairments, some of those things that are still hanging on. And really the importance at that point as well is to make sure, even if you're done with therapy, even if you're at home, you're no longer coming to rehab consistently, you still follow up with the care team. You still follow up with your primary care physician so you can manage any ongoing health concerns, your neurologist checking in. They understand, the mechanisms behind the stroke that they can then work to help prevent. The psychologist to help with those, emotional changes that might still be happening. So that coordinated effort of those specialists together can help facilitate even further progress. Again, months, years after the stroke. And while improvement might take longer for some patients, again, going back to that, keep practicing. There is still hope down the line. And I think it's important to help, really celebrate those small victories. So even if you just need less help with a task, that is a milestone, and that is something to be celebrated. That's moving in the right direction. So keeping that all in mind as you navigate through the rehabilitation process. So I wanted to include some stroke resources for you. So obviously the American Stroke Association is a really nice resource. The Whole Person is a great local resource that is helpful for people who are looking to maybe return to the workforce or maybe needing some extra help, extra supports in the home. That's a great option, great people there. North Kansas City Hospital has stroke support group, and I've got the information on there as well. So again, if you want to take a picture with your phone, but they meet every third Tuesday of the month, it looks like, in the main hospital building on the 4th floor. That's our acute rehab unit. So you can contact them if you'd like to be a part of that. There's also many other stroke support groups in the Northland and in the Kansas City area. So if that one doesn't work for you, I encourage you to, just Google it. And again, the American Stroke Association, I believe, has some good resources on their website if you're looking for something else. Again, I think just all of these are good resources to know about. The Institute on Aging, Alzheimer's Association has wonderful resources if you're dealing with that vascular dementia. CDC has some great guidelines and kind of outlines the recommendations for the stroke rehabilitation. And then if you have any further questions or you want to get connected with a therapist and get that rehabilitation up and running, the North Kansas City Hospital Rehabilitation Department number is right there for you. So that's that 816-691-1795. Most rehabilitation for us is covered with a doctor's order. And we have a team of insurance specialists who check all of that before we even bring you in to make sure that, there's no surprises later on. So we can have a nice plan set and we have all of our ducks in a row as far as insurance goes. And then finally, I wanted to give you my contact information as well. So that number 691-2910 is my direct number at the hospital here. Probably the best way to contact me is email, just because I am seeing patients most of the day. So stephanie.ramirez2@nkch.org. So if you have any questions, I would be more than happy to answer them. And if you have any specific questions to speech, obviously I can answer those. And then if you have anything for our other therapists, I can pass you along to whoever I think would be able to help you. So we are obviously dedicated to helping our patients and trying to get everyone on the right track. So, and I wanted to leave about 10 minutes for questions. So I think we're right at that point now. So if anyone has any questions right now, we can put those in the chat box, or Shanna, you just let me know what you'd prefer we do.
No, absolutely. Thank you, Stephanie. I do want to let everybody know that we are recording this. So if you have a question that you'd prefer not to ask with where everyone can hear, then please reach out to Stephanie directly, but you can use the chat function or the Q&A function with any of the questions that you may have. So Stephanie, I love how you went over what to kind of look out for the stroke as well, because I think that, it's kind of missing sometimes. We may just think, oh, well, my head kind of hurt, or my vision went blurred, but nothing happened. Especially for women, because I know heart attacks present themselves different for women as well.
Yeah.
So knowing that a stroke does too, that's kind of scary.
It is, because I think, again, not a lot of people know about that, or that it is even different for women. So I think, again, just an ounce of prevention is worth a pound of cure. So if you can be aware of what's going on, and be able on the lookout for those symptoms, you might be able to help save yourself or save a loved one in that situation. So
Absolutely.
yeah.
All right. Well, Stephanie, I think we are good. Thank
right.
you very much for meeting with us tonight.
My pleasure.
All right. You guys have a good evening.